Thank you, and well done for hanging on to the last shift of the presentations today. Yeah, well, I'm going to talk to you about pressure ulcer prevention at home, a new study that we've just published actually, looking at using like a participatory approach, which for those of you who don't know, it's like PPI and co-production on speed, and it's not what I'm used to because I come from a very traditional research paradigm, systematic reviews, you know, randomised control trials and that, but I have to say I'm thoroughly enjoying the journey, so it's been really, really wonderful. So I want to give you a little bit, so I'm going to present the first bit, then Laura's going to come up and present the results, and then I'm going to wrap up at the end. So a little bit of background. So this has been in the making for over 10 years now. So in about 2009, I was involved in the purpose programme of research. My main area was developing purpose T. And as part of that, we developed a service user group, the Pressure Ulcer Research Service User Group person, who were a group of service users with who were at risk or have had experience of pressure ulcers, or carers who've had experience of pressure ulcers. And it was really interesting throughout my research involving them in the many phases of the research to develop Purpose T. And this work really, it comes out on the back of Purpose T, because what they said was, that's great, you've got this nice tool for clinicians, but actually what we want is something for us that we can use that can help us prevent pressure ulcers. And so that's when we started to try and get some grant money really, so that we could do a study to really explore that in more detail and how we might empower people to be able to look after themselves. So that's the background. So Pressure Ulcers at Home 1, I say 1 because we're on to the second study now. But the Pressure Ulcer at Home 1 study was, the aim was to understand what interventions people need to help them prevent pressure ulcers at home. And that the focus is on people with long-term neurological conditions, because one of the things that we found was that some of these people live at home independently and actually don't have any clinical input on a day-to-day basis. So they really need to, they're self-caring, they might be self-caring with support of a carer or a paid personal assistant, but they are self-caring and they need to know what they're doing really. So, yeah. And the participatory approach, really put simply, it's research about a group of people who are affected by a problem, and basically it's about them sorting it out and how they want to tackle that problem. So the study that we undertook comprised, I'm not expecting you to read this and there'll be no test afterwards, but just to give you an overview of the methodology that we used. We used something called cooperative inquiry groups throughout the whole of the study, and that comprised of two groups. One group was of service users, so people with long-term neurological conditions and carers, and the other group was paid personal assistants. We kept them separate initially just because we thought there might be some dynamics around that you know, we wanted them to be able to feel free to discuss whatever. And then we set up the groups so that people got to know each other and felt comfortable to be able to share experiences and that. And then the next part was around interviewing other people with long-term neurological conditions, or doing like a mobile ethnography where we asked questions on an app and they sent us things about their daily routines. So the key thing here is that when we conducted these interviews, our service users were involved in every aspect of the research, and so they were involved in interviewing other service users, and we had to do lots of training and things so that they were really integrated into the whole research process, involved in every aspect, in the data collection, the analysis and everything, and the decision making around this study. And then we also met with professional stakeholders, so clinicians, nurses, physios, but also people from some of the third sector, Long Term Neurological Condition associations, MS Society, spinal cord injury. And then we conducted something called a systems mapping thing to develop a theory of change, which was basically around thinking about what we needed to put in place to help support people at home. And I'm going to hand over to Laura now, who's going to take us through the results.
Okay, thank you, Suzanne. It's very warm, isn't it? I'm not sure why I've got a cardigan on, so that was a bad decision. But yeah, so just to, as Suzanne said, in the study, in terms of the results, we had 74 participants contributed across the study. So 31 service users, 8 carers, 9 PAs, 26 professionals, strategic stakeholders. But I think it's important to mention there is crossover between those groups. So some of the people that were service users were actually carers or PAs themselves, and the same with some of the professional stakeholders. So please don't worry about this massive map. I'm not expecting one to look at it in detail, and I am actually going to go through each section of the map with you. But we thought it was really important to be able to just show the complexity for people that are managing their pressure ulcer risk and looking after their skin on a day-to-day basis. This is what it's really like for people with long-term neurological conditions. These are all the different factors that impact their ability to manage their skin. And it's a wider context, for example, your family, work, caring responsibilities, life changes. So each of the yellow box on there you can just about see are actually the themes, the key themes that came out of our research. And as Suzanne has mentioned, all those things were developed in partnership with our service users, carers and PAs. So the first one I'm going to talk about is learning. And we gathered a lot of information about this. We had a lot of conversations with people when people took part in interviews and also through the smartphone app and in the focus groups. And for example, the workshop that we did as well, it was really finding out more about how people learn about their health condition in general, but also about pressure ulcer risk. And people had lots of different PE prevention needs. And with that, people had different experiences of information. So, for example, quite a lot of service users said they'd never actually received any information about pressure ulcers or the risk and the prevention, or they can't remember, basically. And for those people, they felt there was a really big need for more awareness raising. Oh, I was too keen with my pointer. But we actually found there was another group of people that were very, very vigilant about pressure ulcer risk, usually people that had pressure ulcers themselves. And they said they really wanted a lot more information about, well, actually I know how to identify if I've got a pressure ulcer and I know the risks, but what do I actually do if I've got one? Where do I go? What happens next? And these people that do remember receiving pressure ulcer information in terms of prevention really reflected on the timing and delivery of that information. So, for example, people that might have had a spinal cord injury might have been in a rehabilitation unit and might have received lots of information at that time at a very intense period in their lives. So even if scheme management was mentioned to them then, they said it was very difficult to take in that information. So, for example, people would say, well, I had that information when I first had my injury 30 years ago, and at the time I really couldn't think of anything apart from what had just happened to me. And also I think it's important to mention, because we're talking about people with long-term neurological conditions, we also have to think about things like fatigue and cognitive ability. So actually people did mention about information perhaps being staggered or repeated over time, so it was more easier for people to take that information in, and also for that detail to be tailored perhaps from health professionals, so actually tailored to their particular needs. And then in terms of some positive examples, we did find that people had talked about actually speaking to tissue viability nurses, and they'd had some really positive experience of that contact with that type of health professional, and felt that they got a really positive response and some individualised advice. But we did find that they're rarely involved in primary prevention. It's only for categories 3 and 4, so there weren't actually that many examples of that happening. PAs and carers had said they had very limited opportunities to find out more about pressure ulcer prevention, and actually they'd had to really just learn about pressure ulcers over time, so information from other people they met or through health professionals. So we also spoke to people a lot about how they manage their care on a daily basis. And quite a few of them, in terms of service users, said they developed particular problem solving and ways of managing their skin to help ensure they remained pressure ulcer free. And these include certain strategies which you'll all be aware of. So, for example, using mirrors or taking photographs to take areas of the skin that they couldn't see. So, for example, sacrum and buttocks. They also did things like set an alarm on their smartwatch to prompt a position change. So if they're in a chair, it'd be the lift and shift every 20 minutes. Regularly applying the cream. Some people had a very specific daily routine for cream application in terms of, as well as being clean and dry, of course. They might have written care plans for hospital, or if they had to go into hospital, specialist clothing, and also their plans about seeking help. So especially asking their carers, friends and family who might be caring for them, but also PAs to do regular skin checks, including some of the things that I've just mentioned. And when we did the systems mapping, when we talked about these different routines people had, we conceptualised it as more of a, if you like, a safe routine. It's a set of flexible strategies that people could use that's more specific to that particular individual, that also takes into account their clinical risk factors. So, for example, mobility, skin status, of course, sensory perception, which can be very different for different people, and the wider context of their daily lives. But people did also talk about, well, I do have my safe routine, but actually pressure ulcer prevention is just one small part of a massive complex system. You know, for example, they might have multiple conditions. There's lots of other things happening. And self-care was understood very much in broad terms. So yes, it is about physical health, but also about your mental health. And some people did say they felt that that holistic view of care or specific care was perhaps missing in some clinical services. So we talked a lot with people about third sector and peer support. And the third sector was cited a lot as where people would go for advice and information. So, for example, charity websites, charity-funded specialist nurses and helplines, multiple types of peer support are mentioned by people. That could include trained peer support workers, so, for example, within a spinal injuries unit, social media forums like Facebook groups, and also support from friends. And they did talk, we did speak to them about, well, why are you going to charity places rather than the NHS? But people were quite clear that actually they don't always know which part of the NHS to access for information about pressure ulcers, or if it's a specific aspect of their condition, whereas condition-specific charities are seen as more of a one-stop shop for them. They also talked sort of about waiting lists for example, I know it might take me a few weeks to even get a phone appointment with my GP, where I can just go online and I can get information in real time, including out of hours. But people were also very sympathetic about the burden on the NHS. So we did have some service users that said they do try as much as possible not to contact the NHS because they were aware of how overstretched everybody is. And they did express empathy with professionals working in those situations. But I think also people value the life experience of others. So if they're talking to others that have been through similar experiences or similar conditions, that was really more or less a safe space for people for emotional and practical advice. And although people reflected that they'd used third sector organisations a lot, there was increasingly a sense that perhaps more and more is being done by those rather than the public sector. And even though they have all these resources, there's perhaps less contact from health professionals in the home and less of that face-to-face contact. And also when it comes down to peer support, even though they valued it, they were mindful it was actually just some friends or other people, but it would be better to probably link that with more evidence-based support. And then navigating complex systems, which says what it is on a tin basically. None of this will be of a surprise to colleagues in the room, but service users talked a lot about the massive complexities in managing their care. And a lot of that was about negotiating, again, where do I go to in terms of the NHS, who do I speak to, but also social care services, finance, for example, benefits, equipment grants, training grants. And then there's also the area, for example, if they have a PA of recruiting and employing those PAs and training them as well as third and private sector input. And that was a massive mental stress for people as well. And people did report a negative impact on mental health. And some of the people we interviewed did say that that impact on their mental health was actually perhaps more stressful than being in pain and having poor mobility. And service users also reflected that actually it's hard to advocate for yourself if you're feeling unwell or low or you're fatigued. people also said that they usually require cross-medical services, and actually it's difficult. You can't really get one particular appointment that's going to address what you need. You might need multiple appointments. And just generally, service users, carers and PAs said they had to fight to get the support that they needed. And some people fell out with the clinical services either by choice or where they've fallen through the gaps. And healthcare professionals acknowledged the disconnect, that what was happening in terms of differences between what service users wanted and what they could provide. And they also had their own experiences as being family carers, for example, so understood the frustrations. We also did have some feedback about the private sector, both negative and positive, but we don't really have time to go through that today, but there is information about that in the paper that we've had published recently. And adapting to and reacting to change was, of course, a big one. So people have a safe routine in terms of their physical risk factors and their wider the wider context of their lives. But actually, their lives and their clinical risk factors change over time. So people describe danger points in their lives. So, for example, where things could change in terms of their pressure ulcer risk. So life events like moving house, changing job, temporary changes like going on holiday. What happens if I go on holiday and I have a poor transfer, getting onto the plane? Acute illness or injury, again, changes in mood, ageing, deterioration or fluctuation of an existing condition, or developing additional long-term conditions. And people were really unsure about where to go next. Again, if that happens, what do I do now that my situation has changed? And again, some professional stakeholders were frustrated by the lack of flexibility in their roles to be able to adapt to that. In terms of perceptions of risk, there really were differences, and I'll talk about it a bit in a minute as well about negotiating risk. But in terms of perceptions, that was very much influenced in terms of how much risk people thought they had, was influenced by who they come into contact with and how much skincare had been prioritised when talking with healthcare professionals. And as I mentioned before, some people had not appreciated a pressure ulcer, especially if they were younger and thought, well, it's something for when I'm older. But once they'd actually had one, they were very hypervigilant. And, people had said to us, I just need to make sure that it never, ever happens again. It was so awful. And one of the carers said that the only way you could make her husband cry was to tell him that he had a pressure ulcer, because he was so terrified because of what had happened to him before. And it's just to say the emotional impact of that, really. And of course, there's a major impact of PE treatment interventions. If you have long periods of bed rest, you're not really in work or education, you're not seeing your family. And we did have a discussion about how can we improve pressure ulcer vigilance then. We talked about images, and there was a real difference in opinion. Some people thought graphic images of pressure ulcers were actually really good to help motivate them, whereas other people felt it was really scary and worrying, and it actually made them disengage. And then with risk negotiation, this was really a strong theme that came out of the research about when service users are talking with healthcare professionals, and about the different perceptions about what the risk is. And service users said they really need something that's flexible or fit around their existing self-routines and perhaps most importantly their lives in terms of what they can do and what they can do in terms of a lifestyle. And at some point, service users felt that healthcare professionals were unwilling or unable to deviate from standard advice, even when that advice wasn't really practical in the context of what they could do. So, for example, sometimes they felt they were labelled as non-compliant or blamed if a PU had developed or deteriorated further. But from their perspective, there were some things that they just couldn't comply with. So, for example, they had to work, or, as I mentioned before, people had to go and look after their ill mother, for example. But it was acknowledged that these conversations can be complex and really challenging, and that we need strong communication on both sides, and that professionals described the constraints with their role, for example, and they did actually fear litigation if they deviated from what they considered to be best practice, and that perhaps more senior staff appeared to be more willing to accept higher risk levels. And then the last theme is about supporting roles. So I mentioned earlier how people felt that even though third sector organisations were doing more, they were losing some of that face-to-face contact, for example, in the home. But that role has been filled as well by family carers or PAs. And both groups had positive and negative experiences of that. So, for example, informal carers really liked, obviously, that they can support their loved one, and it helped to build trust and resilience between them. It helped to develop their relationship, and they bonded. But some other people really struggled with that, of course, and discussed the challenges they faced in their roles. And then some of them just said, well, I just want to be a husband, I just want to be a wife, I don't want to be just that person's carer. And also with PAs, it was similar, where they felt that they were a part of the family and they really sort of would know them really well and perhaps know them better than some healthcare professionals. But that also meant that boundaries became very blurred at times. They might be asked to do things that weren't within their role. So, for example, doing things like going to shops or driving someone somewhere to go to McDonald's. And that also most PAs don't really see pressure ulcer prevention as part of their role, but they do realise that they're well placed to spot any risks.
So, yeah, practice and policy implications for this immediate work is that basically organisations with a remit to provide health and social care to people with long-term neurological conditions, they need to enable users to access support quickly when a pressure ulcer develops. That was one of the key things, is that people just didn't know where to go or who to contact. So, and often it wasn't recognised, and some of that was related to how the service user might convey, because of their lack of language, if you like, to convey the seriousness of the situation. They could end up in situations where it just wasn't picked up upon and wasn't thought to be urgent, and then, you know, you end up in this waiting game as well. And I think as well, some of what Laura was just saying about the staff feeling a bit confined by their roles, the need to adhere to standard processes and guidelines, and really like the culture of blame and litigation within the NHS, and this can sometimes hamper a person-centred approach, which needs to be flexible. And I think this also relates to the different perceptions of risk, and how actually their perceptions of risk can be altered, and because they're juggling so many different things, they're quite prepared to take a risk with one thing, and that might be the thing that you think they shouldn't be taking a risk with, but actually if they're competent, but that makes it really difficult for professionals. So there's a conflict there, and that we need to kind of work through, so that so clinicians feel supported, but that service users get a flexible approach to their care as well. And independent advocacy roles are needed to help service users navigate these complex systems. I remember in one of the stakeholder groups that a lot of the professionals said, well, we don't know how to navigate the system, so it's really hard for even us to advise people who to get in touch with. So yeah, I think that's something that the third sector sometimes help with. So essentially then, we're using this work, we've not just done it just because we're interested, we're using this work and our findings to help inform the development of an interactive, multi-component intervention, which will include resources for people with long-term neurological conditions, informal carers, PAs, and to some extent healthcare professionals. And this will be an online thing, but we will ensure that there are paper copies available. So that then led to our second study, which is the intervention development component of this work. So we're using them results to create and test these resources. And we've just we started middle of last year, but the intervention requirements there that we identified from all those big systems maps that Laura presented was there's a need for awareness raising. So what is a pressure ulcer, who's at risk, and why do you need to do pressure ulcer prevention? And then support for people to develop personalised safe routines with consideration of physical risk factors, but also the wider factors that impact their lives. And obviously a lot of my previous work has been around physical risk factors, but some of what the contextual stuff that goes on in their lives is really complicated, and the need to be able to respond to that was paramount. Also, we wanted to look at like care escalation and what to do when they did think they've got a problem, how to manage that, how to communicate that with healthcare professionals so that they are helping the healthcare professional to identify that actually it might be a pressure ulcer without overburdening them with all the technological language and categorisation and all the rest of it. And then I think a framework to support risk communication, because the support needed on both sides, on a service user side and carer side, and also on the professional side. It's a really tough nut to crack in like risk negotiation. So I think there's more focus needed there. Oops. It sometimes jumps, doesn't it? So, and this diagram, which again I'm not expecting you to read, but this is it's called a theory of change. And actually, at the one end, what we're looking for is reduced pressure ulcer incidence in the orange box, so the impacts there. And we would propose to do that by obviously people being more aware, being able to, having the knowledge and the skills to be able to spot if there's a problem and identify the right people. And then the lilac boxes, really from left to right, are the stepping stones. So what's critical, we think, is that we involve key stakeholders in this process. So this study that we're doing now is also a participatory approach. So service users, carers, PAs, healthcare professionals and third sector workers are involved in this work. And we're developing this resource so that then people will have an increased knowledge and hopefully then be able to prevent pressure ulcers themselves. So it's quite an exciting project for me, well, I think for everybody actually, because we're involving a design partner in this process as well. And they're helping us with, they're going to help obviously design the website, but also like we're going to use different things like animations to explain things to service users in a way that's a lot more user-friendly, and we'll be testing that process throughout, making sure that it's understandable. And there might be different levels of information that we want to give, because one of the things that came out was that some service users just want to know the bare minimum, and others want to know everything. If you pick up a leaflet, you're presented with what's ever there. You know, you've got that information. But what we're hoping to do is to be able to make it a little bit more interactive, so they can get the basic information and that might be all they need. But if they want a bit more, they can click on this and it'll give them more detailed information about whatever. And there'll be a lot of stuff in there about prevention, and they'll be able to navigate the way around that themselves. So we're hoping in that way it might be a good support for professionals in being able to direct people to this resource so that they can have a work through it and they can work through things at their own pace. So, for example, people wants and needs are different at different stages. If they don't know anything about pressure ulcers, they might start over here on the website. If they've got a pressure ulcer and they don't know what to do, they might start there, and that, so they can access it at different points and different stages. And I think back in the day when I was working more clinically and we developed information leaflets, I'm sure you've all been there, you've done the big policy documents and all the rest of it, and now you want to produce something nice and neat for patients, and it's always the thing that gets last. I mean, there are some really good examples out there, but often it's the thing that gets last, you know, the last sort of effort. And I feel like we probably need to make more emphasis on this and how we kind of can communicate these things with service users to support them at home. So that's the next study, and you'll be hearing more about that as we work through it. If you want to know more information about the study that I've just presented and the results that Laura just presented, then the study has been published now in the Journal of Tissue Viability. It was last year, so that's there. And I just want to acknowledge all the members of the cooperative inquiry groups, the interview and app participants, the members of Person who really, without who without this we wouldn't have even done this grant application and be doing this work. And also members of our project coordination group. And a big thank you to Delia, who's actually on. Delia played a really significant role in our work. She's actually on maternity leave at the moment, otherwise she'd be here doing this. And also we just need to acknowledge our funders, which are the NIHR. Thank you.